or even fellow rheumatology fellows, we tell them you have to say the magic words, AP view of both hands, and then tell us the age of the patient or sex of the patient, and then start from the outer side till the inner side. So we'll say, look at the soft tissue. There is no swelling of one of the fingers or joints. Sometimes the shadow shows. So there's no swelling, and there's bilaterally as well. You have to look at the other side. There is no calcification in the soft tissue. So soft tissue, number one, no swelling, no calcification. Two, you go to the bone and see and find if there is any breakage in any point. So we go like this, like this, like this, nothing. And you do the same thing here and say no fracture at all. And then you can discuss the mineralization, or you call it osteopenia, whether it's generalized osteopenia throughout the whole bones, many bones, or you can specify and say periarticular, around the joint, periarticular joint osteopenia. So periarticular joint osteopenia can be seen in chronic inflammatory arthritis, such as rheumatoid arthritis or psoriatic arthritis. So number one, AP view. Number two, you say the calcification of the soft tissue or swelling of the soft tissue. Number three, bone, and then you talk about the bones in terms of generalized osteopenia or specified or periarticular osteopenia and fracture. Then you talk about joints. Oops. So the joints, you say, well, I can see the joint space, because the joint space is simply tells you that there is a cartilage, and it tells you that there is this normal space. So here you can see beautiful black line in the carpal joints, in the radio-ulnar joints, the distal one. You can go up front and say, or distally, to talk about the metacarpophalangeal, MCPs, metacarpophalangeal. And then you talk about proximal interphalangeal and distal interphalangeal. Each of those joints in our rheumatology mind is associated with certain disease. Now, I'm here to convince you to read these x-rays now with a trained eye, knowing the more common diseases, actually. So there is no distal and proximal in the thumb. There is only interphalangeal. Thank you very much. That's all about the hands. Now you need to read more and more of the x-rays so you become trained. So this is osteoarthritis, the most common arthritis worldwide. So patients come to you with stiffness, but stiffness does not usually last longer. And it's like maybe 10, 15 minutes max. It doesn't stay longer. And patients have these swelling at the distal interphalangeal joints, and they tell you, oh, I have a swelling. But when you palpate it, it is hard. And the hard part is this. This is the Hibberdin's node, the scientist who somehow magically discovered that I'm going to call it after my name. Hibberdin's nodes. So it's basically osteophyte. It's a reaction from the bone itself when there is less cartilage and there is friction. So it happens that there is 4 cardinal signs of osteoarthritis. The one of them is subchondral sclerosis. So here, well, it's not unfortunately in this picture, but it's supposed to be some sclerosis, subchondral cyst, and then osteophytes, and of course there is the narrowing of the joint space. Classic teaching for family medicines, for rheumatology fellows, for internal medicine. We always teach this, even for medical students. So this is a Hibberdin's node, which is simply called node, but it's osteophyte, and you can palpate it. Next, there is some entity called erosive osteoarthritis. Erosive osteoarthritis, we love the sign called seagull sign. Seagull. So here, it's like a seagull. It's like a wing. So there is a central erosion, and there is some kind of sclerosis and other signs of osteoarthritis. And patients have pain. Sometimes, occasionally, they have high CRP, but they are really painful. And it's just different, a little bit different compared to the normal osteoarthritis, in a sense that there is more inflammation and more erosion. So what we do here is sometimes I inject those joints with steroids. It makes them very happy. I remember a patient who was a mother of my rheumatology colleague. She asked me and said, Ramadan is coming, please help me. I said, I'm going to inject you in all those 3 joints. Is that okay for you? At that time, 7, 8 years ago, there was a randomized control trial that showed that injection in those kind of patients helps. So I used that randomized control trial, injected her, she prayed for me. The whole Ramadan, no pain, she was able to cook and everything. But knowing the erosive osteoarthritis is critical. So remember, seagull sign, central stenosis, central erosion, and like a seagull in here. It's mostly on the distal, interphalangeal, and proximal. It doesn't come in the metacarpal or here. Next, this same picture, I'm just showing it to you, and if you can see it from far away, same picture. Here is knee osteoarthritis, another place of osteoarthritis. It's showing you the beautiful, on the left side, articular cartilage, meniscus, and normal joint space. Look at the bad osteoarthritis. It's the most common osteoarthritis and mostly common in obesity, which is the epidemic of this age, and also if there is a family history. So you can see cartilage loss, joint space narrowing, and joint spurs or osteophytes. This is the, it's called, I think, there is a grading for it, grade 0, normal, slightly normal, it's almost normal. Radiologists would call it normal. But then you start slowly to have narrowing only unilaterally, not the whole joint. Unilaterally, it's one part, not the whole part. You see, until you start to reach. So you can see here that there is more sclerosis, and there is osteophytes in here. Then we have hip osteoarthritis. You can see that the hip osteoarthritis, normally there's supposed to be a normal joint space, but then the first part of the joint is there, the superolateral part. Superolateral part here. They start to become narrow and narrow. And because there is continuous friction, there is sclerosis on this side, and then beginning of osteophyte. Same teaching for medical students. 4 cardinal symptom signs of osteoarthritis. Narrowing of the joint space, subchondral, 2 subchondral sclerosis, subchondral cyst. And because cyst, it becomes some like vacuums in there. And then finally the osteophytes. So 4 cardinal, same issue. Here is the very bad one, osteoarthritis in the right side. Here is another advanced one. Look at this. It's gone. Khalas. Bye-bye. No space. Khalasna. And there's a lot of sclerosis. So this requires replacement. Next, neck. This is normal neck X-ray. Look at the beautiful normal X-ray. You can see here, you can see a black line, which means there is a facet joint, normal is facet joint or apophyseal joint. Okay, this is the same picture, another patient. Look at this now. Disc space narrowing from C4 to C6, 7 is present. Look, there's a disc space narrowing. Very bad. And also some osteophytes. Look at this, another patient. You can see that there's narrowing of the space between C5 and C6, and arising from with osteophytes, arising from adjacent bony margins with both anteriorly and posteriorly. The remaining intervertebral spaces are, and posterior articulations are normal. Findings are consistent with osteoarthritis. Encroachment on intervertebral foramina may be demonstrated on oblique radiographic projections. Here, a little bit of beginning of facet joint problems. But spondylosis refers to the formation of osteophytes in response to osteoarthritis. We call it spondylosis. This is another patient with, this time, facet joint or apophyseal joints. These are the joints that allow you to do this and the back. So back and then on the lateral side. So there is pain actually in these joints. And you can see the x-rays, the space, the black mark that I showed you here. You see beautiful black line, it's gone. Okay, this is gone, khalas. So lateral view of the cervical spine shows normal intervertebral spaces and bodies, narrowing of facet articulations and sclerosis of their adjacent margins are present. These are the arrows. These findings represent true degenerative arthritis of the cervical joint. So we're done with osteoarthritis. Let's talk about ankylosing spondylitis, the disease we love. But it's nice to know as an internist. It comes in the Arab board exam and the internal medicine, other exams. So this is, again, we're talking about facet joint. You remember the black line? Gone, no black line. So this indicates facet joint and also some ossification in here at the beginning. It's a thin vertebral ossification. Look at this, another patient. Here you can see the beginning of ossifications, but here is pure ossification, complete and complete. So that's one of the signs of ankylosing spondylitis. The sacroiliac joints, you ask the radiologist to do an X-ray. Either you do sacroiliac X-rays or pelvis with hips. They're same. But some books, they say sacroiliac X-rays is better. But some other research in the world of rheumatology says they're both fine. But this is grade 0, which means normal. Grade 0 sacroiliitis, so normal. There's patient complains of pain, but there's nothing on the X-ray. Look at grade 1. You can see starting sclerosis here. Okay, not much of joint space narrowing. Look at here, grade 2. There is some narrowing, and it's like a rat eating it, a rat bite. And grade 3 is very obvious, more sclerosis, and then rat bite as well. And grade 4 is complete ankylosis, which in Greek means fusion, التحام. التهاب الفقار الالتصاقي أو الملتحم. So complete fusion. Thankfully, not all patients have this. Mostly men, and not all men like this. 40% of men have this ankylosis after 10 years. So this is another picture, another image, which shows you that the sacroiliac is eaten up. Please start practicing. Read. Start practicing, actually, and read your X-ray by yourself. Sometimes we disagree with the radiologist and say, I'm sorry, your reading is completely inaccurate. My reading is better. Because nowadays many of the radiologists are moving from the X-rays into the world of MRI and sophisticated imaging, so they are losing the skills. And this is not only happening in the UAE, we also had the same conversation and discussion with our radiologists when I was training as a fellow in Toronto. This is complete ankylosis, complete fusion. You cannot see the black line coming from top to bottom. And this is, but be careful. There is an entity called osteitis condensus ilii, more typically in women and after vaginal deliveries. So this basically doesn't, the narrowing is, there's no narrowing of the sacroiliac joints. There is a triangular calcification in the ilial side of the joint. So you see it's like a triangle here, and usually bilateral. So that's another entity that does not require biologic and does not require our immunosuppressive drug. This is totally different. I know some women hate it and they tell us I'm in pain, so we give them NSAIDs and physiotherapy. But there is no randomized controlled trial that was conducted in those kind of patients. So be very careful in this. And maybe it's good to read your own X-rays as well. It's a triangular area in the iliac side that actually is with sclerosis. It's osteitis condensans ilii. So this is another picture which we all see in our boards, thoracic and lumbar vertebrae squaring. This is a squaring. It's become a square. There's normally convexity, convex, muqa'ar. Convex, but there's no more because of the calcification that starts from top to bottom. So basically you lose that concavity and become square. And also there is an ossification, not in this scenario, but in this scenario. You can see beautiful vertical, thin ossification. This is classic ankylosing spondylitis. But when you flip that diagram into the AP view, the normal anterior-posterior view, you see bumbo spine, the classic exam question. Bumbo spine. Now, psoriatic arthritis. This picture, there is pain and swelling of the apex of the and the MCP, metacarpophalangeal, of the index finger, index here. But you can see that there is erosion as well. And there you can see in the same index finger, there is resorption of the terminal tuft. Classic of psoriasis. Classic, actually. Not all the time you see classics. Sometimes you catch the patients before this whole thing. So it could be normal. It could be periarticular osteopenia. I don't know. But this is one of the examples I wanted to show you, that tufts can be resorbed, and sometimes there is periosteal reaction, like periosteitis. This is another picture showing the tuft resorption. It's the same patient, but over time, and you can see the tuft is bye-bye, is gone. And this another patient showing you that penicillin shape in those patients actually, and there is bad deformities, especially in patients with uncontrolled psoriatic arthritis. I've seen 2 cases in the UAE, young women, 35. And unfortunately, one of them said, I don't want to take your drugs, I'm fine. It's like, why are you coming to my clinic? Well, I want to see if there is any drug without side effects. So, no, there's no drug without side effects. Bye-bye. And she left. Because she refused. I can't convince you. Every drug has side effect. So unfortunately, cases I've seen. So rheumatoid arthritis, very common. You can see the hand, metacarpophalangeal is one of the main joints that there's a problem with rheumatoid arthritis. Rheumatoid loves metacarpophalangeal and proximal interphalangeal. Doesn't like distal that much, but mostly metacarpal. Look at this over time. You can see that there is thinning of the cortical bone, and bye-bye. It's eaten up like a rat eating it. So that's called erosion. And that's the end result, the end game of the rheumatoid, one of the end games. So we try to prevent that by using our fancy, expensive biologics. So there's another one with advanced deformities. I'm sure you've seen that in your practice. You can see that there is ulnar deviation, and there is marked narrowing and subluxation and ulnar deviation at the MCP levels. In the Arab board, we always tell we reduce one mark if they don't say at the MCP level. You have to say ulnar deviation at the metacarpophalangeal level, not ulnar deviation khalas, because there are levels. There is erosion also in the metacarpophalangeal. You can see some erosions here, eaten up. Proximal interphalangeal are here. You can see that there is a narrowing of the space. It's not like the normal joint. And there is periarticular osteopenia, as I told you. There is osteopenia around the joint. You can see beautifully from here. And carpal joints are narrowed, and erosions obviously are there. And there is also erosion at the ulnar styloid process. Jacquard's arthropathy is an entity or a sign that is seen in disease such as lupus. It's deforming, but non-erosive and reducible. You can put it back compared to rheumatoid. So that's a very important, actually, distinguished. It came in my rheumatology board, actually. This, finally, the feet deformities, severe abnormalities, and you can see subluxation of all metatarsophalangeal joints, and there is hallux. Hallux is like this, hallux valgus. There is obviously osteopenia and erosions and lateral deviation. Classic rheumatoid arthritis that we rarely see, but in elderly women who have not been treated before. That's metatarsal erosion here. Where is that? Here, sorry, here. You can see different. It's totally different compared to that one. It's eaten up because of the uncontrolled disease. Finally, we have a couple of more slides and I'll be done. Psoriatic arthritis. Oh, no, I've done this. Khalas, alhamdulillah. I thought I didn't do it. Chronic gouty arthritis. This is gout. We always talk about gout. Look at this. Uncontrolled. Horrible. Classic exam question. Horrible, actually. That's like the whole thing is eaten up. Like a rat bite. Calcium pyrophosphate deposition, CPPD disease. And I don't know whether you can see it from here, but you can see there is a chondrocalcinosis here in the second metacarpal joint. You think of chondrocalcinosis as seen in hemochromatosis, but just think about it as well. But classically second and third metacarpophalangeal. Here is another one, but we look at here in the wrist joint. This is not supposed to have a chondrocalcinosis, but there is chondrocalcinosis. Sometimes it manifests as gout, but it's longer and it's elderly patients. Chronic renal insufficiency. Calcific tendonitis in the shoulder. That's, you can see an X-ray, beautiful X-ray of the shoulder, calcification. And finally, another chondrocalcinosis, but here you can see the crescent sign. See here, beautiful. It's chondrocalcinosis. It's basically calcification in the chondrocytes, يعني اللي هو في الcartilage. Oh, بس خلصت. I'm over time. So that's this.